It was a fine morning. David reached his office. He was at his desk just like any other day, sipping his coffee. When he started staring deeply at the calendar on his wall, he felt a sudden strange disconnect. He noticed a slight tremor in his hand as he held his cup, a tremor he couldn't quite explain. For years, David had lived a normal life, but the pressure of his career had led him into a cycle of heavy alcohol consumption. He thought it was just stress, but soon his life began to fracture. His sleep-wake cycle completely inverted. He would spend his days in a daze at his office, struggling to keep his eyes open, only to pace his home in confusion throughout the night. He started losing focus on his daily tasks, and when his colleagues asked him about dates or deadlines, he realized he didn't know the answer. He was getting scolded by his boss, but he kept telling himself it was just the stress he was going through. Things escalated. He became a stranger to himself. He started snapping at his colleagues, acting with an arrogance and irritability that was completely out of character. In meetings, he would lose his train of thought, and on one occasion, he even laughed at a moment which was clearly inappropriate. What he didn't know was that his liver, now struggling with cirrhosis and portal hypertension, and had lost the ability to filter the toxins. Ammonia, usually produced by the liver, was now bypassing the system and crossing the blood-brain barrier. His attention span vanished. His personality changed. The calm man was now replaced by an irritable and anxious stranger. When he finally realized something was truly wrong, he wasn't just stressed. He was entering into the world of overt hepatic encephalopathy. Then he immediately consulted a doctor, and the doctor performs a physical examination. And then the doctor asks him to extend his arms and flex his wrists back. After releasing, his hands jerk downwards in a flapping motion. This is called as asterixis test. At the hospital, the clues were undeniable. The physician noted the characteristic breath smell, fetor hepaticus, which is a sweet, musty breath odor. Physical examination revealed the classic stigmata of chronic liver disease. The signs of portal hypertension like abdominal distension from ascites and those flapping tremors, asterixis. This wasn't just a mood swing, it was neurotoxicity. When we encounter a patient like this, we don't start by diagnosing hepatic encephalopathy, we start ruling out everything else that could mimic it. We have to differentiate this from intracranial hemorrhages, subdural hematoma, electrolyte imbalances, CNS infections, and Venix encephalopathy. Our initial workup is broad, but it is essential. We do fingerstick glucose to rule out hypoglycemia. Basic lab investigations were ordered, including extended electrolytes, kidney functions, and liver enzymes. For infection screening, a chest X-ray, urine analysis, and blood cultures were ordered to look out for common precipitants like bacterial infections. While the diagnosis is primarily clinical, we do use specific tools to support our findings. We check ammonia levels, which are usually elevated. A serial decrease in ammonia can help us track the efficiency of our treatment. We also turn to imaging, a non-contrast CT head to exclude the acute intracranial pathology like a bleed. We perform a diagnostic paracentesis if there is ascites and use CT or MRI of the abdomen to look for large portosystemic shunts or signs of infection. If the patient's symptoms are subtle, we utilize the neuropsychometric test to quantify the disturbances in attention, fine motor skills, and memory. In more complex cases, electroencephalogram can detect brain activity abnormalities which are characteristic to hepatic encephalopathy, though it cannot distinguish hepatic encephalopathy from other metabolic causes. The path to recovery is a targeted one. We use lactulose, a non-absorbable disaccharide, to act as an osmotic laxative, flushing the ammonia-producing bacteria from his gut. We pair this with rifaximin, an antibiotic that stops the gut bacteria from producing more ammonia in the first place. We don't restrict the proteins as he needs the nutrition, but we manage the precipitating factors like electrolyte imbalance, constipation, and dehydration. Hepatic encephalopathy is a daunting complication, but with early recognition and the right clinical approach, it is reversible. Keep watching and keep simplifying the clinical medicine.